Good morning. My name is Pat Clancy. I'm Vice President for Public Health and Education at the Medical Society, and I'd like to welcome each of you to the Medical Society of the State of New York, Medical Matters. Medical Matters is a one-hour continuing medical education webinar that is held on the third Wednesday of the month. MSSNY will begin regular programming on Medical Matters in 2015, and Medical Matters is sponsored by MSSNY's Committee on Emergency Preparedness and Terrorism and Disaster Response. Today's webinar will provide each participant with 1 hour of continuing medical education credits and will go from 7:30 to 8:30 a.m. At the end of the program, you will also complete a CME evaluation of today's speaker. This will be posted at the end of the webinar for each participant to complete. Your CME certificate will be emailed to each of you within the month. If you are attending the session at a local hospital or a public health department, or if you are participating just by phone, we ask that you send us your name and your email so we can provide you with your certificate. You will be muted for the majority of the didactic presentation, and there will be a question and answer period at the end. To ask a question, you can either raise the hand located in the box to the right of the PowerPoint or send us a question via the chat. Please remember to click on your hand after your question has been asked. This will allow us to move through the questions in the allocated time frame. I would like to state that I, Shakira Kramer, Dr. William Valenti, have no financial interest in any portion of today's program. Today's program is entitled Ebola, What Physicians Need to Know, and our faculty is William Valenti. And Dr. Valenti is an internist and an infectious disease specialist and a native of Rochester, New York. He is co-founder of Community Health Network, a not-for-profit medical clinic caring for 700 people with HIV and AIDS in Rochester, New York, and it's now known as Trillium Health. Dr. Valenti is a graduate of the Medical College of Wisconsin, did his infectious disease training at the University of Rochester, and is a clinical associate professor of medicine at the University of Rochester School of Medicine. He has been involved in HIV treatment, research, and policy in the United States since the early 1980s and is chair of the Medical Society's Infectious Disease Committee. He is also a member of the Medical Society's Committee on Emergency Preparedness and Disaster Terrorism Response. Dr. Valenti serves as a faculty for the Medical Society's various educational programs and has authored several of these programs, including today's program. And with that, I'd like to turn this over to Dr. Valenti.
Objectives. We're going to summarize Ebola and really focus on this 2014 outbreak. There are several subtypes. The subtypes that we're talking about, the original Ebola strain Zaire, which is a human-to-human transmission strain, is what's involved primarily, and then more recently the Sudan version has popped up. But there are several serotypes, all of which are transmitted human-to-human. The Reston version, we'll talk about that. That is not something that's transmitted person-to-person, and the reservoir is animals. So let's get started here. Historically, Ebola was first identified in 1976. What this map does is summarizes that activity by year. The larger the circle, the greater the number of cases. And you can see that for the most part, it's restricted to a band across Central Africa. The current outbreak is really focused more on Western Africa, but it was discovered initially in 1976 in what's now called Democratic Republic of Congo, which is more central. So the reservoir versus host. Here is the quick summary of the reservoir, which is primarily fruit bats. in the African bush country, and in terms of intermediate hosts, in addition to the bat and other animals and non-human primates, what we're really going to focus on is the human host, because it's humans, people, who play a major role in these epidemics that we're currently seeing in Western Africa. Here's just another summary that talks about magnitude, or tries to quantitate what we've been seeing here. You've probably read that the current outbreak that started in March of 2014 is the largest and most serious of the outbreaks or epidemics of Ebola. And the rest of these circles just sort of quantitate in relative terms the magnitude of the outbreaks. But in terms of numbers of people infected, the current outbreak that started in March is considered to be the largest and the most serious. Now, people often ask, well, have we ever seen hemorrhagic fevers or Ebola virus in the United States? And the answer is yes. All imported cases. There are no reservoirs of Ebola in the United States, but there are reported cases, first reported as early as 1969, and that involved imported Lassa fever. Most recent case in 2014, a traveler from West Africa to Minnesota. The Marburg virus, which is also a filovirus or family member of close relative of Ebola, has been seen in Colorado. And the interesting thing is these hemorrhagic fevers cases with either Lassa fever or Marburg brought into the United States by travelers. There's been no secondary spread. There's been no secondary spread, and I think that is it's important to keep in mind, because as we talk about transmission, some of this will begin to make sense and come together. The other interesting thing about Ebola in the United States is this outbreak in an animal care facility in 1989. Macaques, non-human primates imported from the Philippines, were sent to an animal research facility in Western Virginia. And this virus was not identified until a bit later to be an Ebola family member, and it was named Reston. Several of the animals died, but the interesting thing was, if you look at the right-hand column under human infection, there were a small but measurable number of animal handlers who seroconverted, who became antibody positive to Ebola, but did not get sick. Similar situation in 1990, a lab accident in Germany with a needle stick, where there wasn't even seroconversion with this Ebola-containing blood. So this is a unique family member or unique Ebola subtype, because while it affects animals, non-human primates, it does not appear to be spread to humans, and that's not so. It's not. While these animal handlers may have seroconverted and became "quote unquote" infected, they did not develop disease, and it doesn't seem to go from person to person. So this is a unique outlier in the Ebola family. Let's get back to the Western Africa outbreak or epidemic. Here's the case count as of the end of August. Total cases that we've on the slide, just over 3,000. About half of them have died. Note the mortality rates in the four major countries affected range from about a third, 33%, to 65%. But the total mortality rate of 51% is considerably lower than what has been reported in previous outbreaks. The very earliest outbreaks in the 70s through the early 80s had mortality rates that have been reported at about 80 to 90%. The thinking is that perhaps earlier and better identification, more prompt isolation, and better efforts at supportive care could make a difference. There have also been a couple cases that have popped up in the Democratic Republic of Congo. As of September 9th, they had 62 cases, 35 deaths, about just over half of the people have died. The interesting thing is this is not related, the Republic of Congo outbreak is not related to the Western Africa outbreak because it's a different strain. It's closer to the Sudan strain. And when we talk about mutations and transmission, we'll come back to this concept. But for now, just talk about the case definition. There are a lot of words here. I'm not going to read it to you, but I want to summarize, first of all, the categories of cases: a person under investigation, a probable case, or a confirmed case. The easiest is the most straightforward, anyway, is the confirmed case, because this is laboratory confirmation, usually using the PCR or nucleic acid test, a very sensitive and specific test, confirmed case, laboratory confirmation. The other cases, either under investigation or probable, require a combination of clinical criteria and epidemiologic risk. Clinical criteria, very briefly: fever. Fever of 101.5 or greater, and additional constitutional symptoms. The epidemiologic factors address the issue of having been there, of having been in a place where Ebola virus disease is active. So putting all of these pieces together, we have a case definition which helps zero in on, and it's more specific for Ebola virus disease so that we don't count other things. Because in some of these very early cases, there was confusion with other exotic or tropical diseases, including malaria, Lassa fever, and Marburg. I'm looking at the phone. I should be looking at the screen here. I apologize. The other part of the definition involves intensity of risk or exposure risk levels. Briefly, categories are high and low risk or no risk at all. Let's get low risk out of the way. Walking by a person with Ebola or walking or moving through a hospital, no risk. So people who are walking by Emory Hospital in Atlanta are not at risk. High risk, percutaneous needle sticks with a contaminated needle, or direct contact, other kinds of contact, note, without personal protective equipment. Highest risk. There are some lower risk categories that are also a part of the case definition that are less intense risks in terms of either household contacts or have distance requirements. This is the much more detailed version. I'll leave this in for the web version for those people who want to read the details on the exposure risk levels. But let's talk a little bit about clinical issues. First of all, incubation period, 2 to 21 days. The mean is around 8 to 10 days for incubation. But note that Ebola virus is a multi-system disease. It makes people sick. The first signs, as I said, fever 101.5, and constitutional symptoms. It has this flu-like presentation to it. But again, in Africa or in places where tropical diseases are seen, it can often be mistaken for, or the differential diagnosis includes malaria, Marburg, and Lassa. And then you can read the other signs and symptoms, but it's safe to say that it really is a multi-system disease, because once virus enters the body, it really enters the bloodstream and becomes, and people become viremic with dissemination to multiple organs. A pathophysiology, in brief, is this. You can see down at the bottom is the graphic version of the Ebola virus. It's a member of the filovirus family, this whip-like or thread-like agent. These little spikes are the attachment proteins, so that virus can attach to cells, and viral RNA is the zigzag material in the middle. So entry is really by skin or mucous membranes, and the virus has a predilection for endothelial cells. And what happens is, with this rapid multiplication or rapid viral replication that can often be rapid enough to evade the immune system, there's a disruption of cell function and architecture, and part of that pathophysiology is a major destabilization of the vascular system that sets the coagulation cascade in motion, destroys vascular endothelium, and is responsible for the hemorrhagic component of Ebola and other family members. Getting back to the current epidemic in West Africa, started in Guinea in March of this year, but has also impacted Sierra Leone and Liberia. The cases in Nigeria is to the east of this major zone, and there's also been one related case reported in Senegal in a traveler from New Guinea. The map at the bottom left just sort of shows you the area in question here, which is really a small part of the whole continent and localized to these four countries, plus Democratic Republic of Congo that I mentioned earlier. So this is the zone where the epidemic is currently located. The 2014 epidemic, this is through August, end of August of this year. You can see overall mortality is 54%. Top line is the number of cases reported that includes, remember that case definition. So we're trying to zero in and be precise here, of probable and confirmed cases, with death rates climbing a bit, but seems to have leveled off through the month of September, just over 50%. And I think this again speaks to getting people into medical care promptly and getting the supportive care that people need. However, it's a moving target in terms of case count, because there's always a lag, and you will see case numbers reported that are significantly higher than what I showed you on the previous slide, just because this is a work in progress. In terms of contagion, this is a picture of one of the isolation units in a European hospital. These are really rooms within rooms, so that this plastic or material can be removed and usually disposed of rather than cleaned and replaced. High intensity air handling systems, and people, as you can see, in a high level protective garb. Before we talk any more about contagion, let's just go back to how infectious agents are transmitted. I think this is important, because as we begin to try and understand this ourselves and also be able to be comfortable answering questions from patients, I think it's important to have some context here in terms of how are infectious agents transmitted. And I think the first point that I'd like to make is not all infectious agents are transmitted the same way, and not all of them are transmitted through the air. And the transmission really depends on the agent, the mode of transmission, which is unique to that agent, and the type of contact. Agents we know, viruses, bacteria, other. There are three major categories of infectious agent transmission. Airborne. When we talk about airborne, we're talking about small particle aerosols that are transmitted 6 feet or more. Did you like that? The close contact mode of transmission is really different, and that's what we're talking about when we talk about Ebola. These are droplets or large particles that contain virus, and because they're heavy, they don't go more than 3 feet, and they just fall to the floor, or gravity takes care of it. So airborne, fine small particle aerosols, close contact, larger particles drop to the floor, parenteral, blood, needles, and sexual contact. So how's Ebola transmitted? Here's what we know, and this is pretty good in terms of 40 years of experience of watching this virus and understanding and drawing conclusions about how it spread. Direct contact with blood or secretions from an infected person. That's the direct contact we just talked about. Exposure to objects, contaminated needles, that's the parenteral way. But the other thing that's unique about this is that a number of cases, and some of them, some of the original cases, may have been the result of contact with blood or tissue from infected animals. Remember that butchering and preparing animals, infected animals, as a food source can be a significant mode of transmission when it comes to Ebola. That's the bushmeat problem. We'll talk about that in a minute. Patients will ask, well, are you sure? And my answer is yes. This is what 40 years of experience has shown us. Can it be transmitted through the air? We've already talked about that. It's not airborne. Can I get it from somebody who doesn't have symptoms? No, because the period of contagion starts when people become symptomatic and viral load, amount of virus in blood, begins to increase and gets disseminated from other tissues. And food or water, well, certainly not from water. The virus is not waterborne, but we already talked about, it depends, that Ebola can be transmitted when you process or eat bushmeat of an infected animal. There are a number of anecdotes that talk about secondary spread, and this is one of them we already talked about. Remember the laboratory issue of Western Virginia where there was no person-to-person spread. This is, many of us have read about this American man who worked in Liberia and went to Nigeria on a work assignment. He was sick on the flight, so he was early symptomatic and was hospitalized on arrival in Nigeria. When he got there, they thought he had malaria. He was positive for malaria, so they treated him for that. Later learned that he had Ebola. Here's some of the experience of follow-up under activity, follow-up of the people on the plane, however, and the passengers on the flight, those who were surveyed and monitored, there was no evidence of infection. There was, however, transmission from this patient to medical personnel in Nigeria, including, four hospital works, not dollar sign, 4 hospital works, and 2 of their spouses, for a total of 6 people infected. Again, at least anecdotally, but when you put all of this together, it supports the idea of needing direct and close contact for transmission as opposed to even sitting next to someone on the airplane. There are other airplane stories like this, and we've not seen much in the way of transmission. The Canadian study that's often quoted really did not show aerosol transmission. You may have heard about this. There's been a fair amount of discussion and hype about it, but the story is, here's the laboratory setting. What they concluded in this study from Canada is that pigs, while not a reservoir for Ebola, can be an intermediate host, and they were able to show transmission in a laboratory setting from the pigs to non-human primates, macaques, in these cages. The airflow was designed to direct the flow from the floor to the cages, and they concluded, there are a number of conclusions from this. What all of this says is that their experiments mimicked the farm setting and really supported the idea of transmission from pigs as a host to non-human primates. But there was no airborne transmission. It was really fomites. You can look at these conclusions later. A citation from Nature is available, but I really wouldn't spend a lot of time focusing on this because it did not show airborne transmission. I think the message here is to avoid data over-interpretation. We've got some projection data that suggests 20,000 people might be infected over 9 months. That's a projection. I think that we could probably thwart that with more aggressive case identification and capacity building. The Gates Foundation has risen to the occasion, Bill and Melinda Gates Foundation, with a $50 million pledge to the effort, along with major countries, including the U.S. But over-interpretation, I think the Canadian study has been very much over-interpreted. The other area is the issue of viral mutations and their relationship to transmission. Just very briefly, mutations occur in viruses as they replicate. The interesting thing about Ebola, though, is it's really not very efficient at generating mutations. It's about 100 times less efficient at creating these mutations than is the influenza virus. The question is, well, if the virus mutates, can it then become airborne? Well, yeah, but after 40 years, that's not happened. Same thing with 35 years of experience with HIV, which is much more error-prone and mutation-prone in terms of its replication. There really has been no change in transmission. I think the real answer here is to focus on the science as we know it. And that's how I would answer that question to patients, is let's focus on the science and what we know. We've already, and we'll talk about infection control hype in a minute, but let's talk about infection control that works. And we're talking about standard contact and droplet precautions, and this is certainly what's in effect in the various places where the epidemic is ongoing, and also the kinds of things that we would need to do here should we have a suspected case of hemorrhagic fever or Ebola in a traveler from a place where Ebola is active right now. That would be somebody from one of the countries in Western Africa who came to the United States and presented with fever, which is what's happened a couple times in the United States on both coasts and also in the Chicago area. So this is a fairly standard infection control strategy that talks about isolation in a private room, wearing appropriate gowns, gloves, and masks, visitor restrictions, again, to just quiet the situation down, keeping track of who goes in and out of the room. This is the logbook idea, avoiding aerosol generating procedures. I know that this may sound excessive to people who argue the point about, well, if it only is transmitted only by close contact, why are you taking all of these precautions? And the answer is, it just makes sense to do that. And that's what we're doing, because we wanted to really have the highest level of containment possible that minimizes any possible risk of direct contact with virus. And don't forget hand hygiene here, which is still critical to the effort. A reminder again about the period of contagion, not during the incubation period, but happens when people get sick during that symptomatic phase. And that's when virus begins to accelerate in terms of replication, and over the next 72 hours after the onset of symptoms, there's a ramp up, what's called a ramp up of viral load or viral burden, and that's the time when people are most contagious to others through direct contact. So why are we seeing this now? What has changed? Some people say, well, has the virus changed? And the answer is no. The virus is the same. Africa has changed. And there are a number of social and political issues that are related to virus spread. Mobile populations, people are moving around much more. Highway construction in Western Africa has made a huge difference. Air travel, a significant player here. Unfortunately, the health infrastructure is really lacking. Look at the numbers here. 2.3 healthcare workers per 1,000 in parts of Africa, in Western Africa, versus 25 per 1,000 in North and South America. Civil war, the political situation diverts resources. Liberia just came off a 10-year civil war that ended in 2003. People mistrust the healthcare system and don't seek care and stay home, and there can be spread within households. There was a Nigerian doctor's strike that stopped just as the epidemic was gaining some legs in that country. And then there's also stigma. So there are a whole bunch of things that contribute to this, but the virus is the same. It's where it lives that's changed. Body fluids, just to get an idea of the role of body fluids here, shedding a wide variety of body fluids. In one study in Sudan earlier, in an earlier outbreak in 2007, 16 of 50 for patients or so, a smaller number of environmental specimens. So I think this points to the importance of cleaning the environment. That actually, remember we said that those small or large particles settle, but actually environmental specimens were not a high prevalence of activity in terms of virus. So, well, if it's not that contagious, then why do we take all these precautions? I think, again, these are interesting books and movies, but we really need to start with explaining this based on the science. Remember that the healthcare system in the United States and developed countries is very, very different than what we see in parts of Africa. And along with an increase in the number of cases, people are scaling up their efforts in terms of expanding and building a stronger healthcare infrastructure. So both things are happening at the same time. Humanitarian efforts, Doctors Without Borders, other mission-driven organizations are actively involved in expanding the healthcare system in the affected countries, because their systems are clearly overwhelmed. And in fact, a number of hospitals have closed in Liberia, which is a major focal point for this epidemic. And hospitals, in fact, have been called amplification points for Ebola, simply because the capacity and the infrastructure within that healthcare system just isn't able to respond. So what do you do then? Well, what about containment? What are the public health countermeasures here? We've talked about isolation and quarantine, which can certainly extend to the individual patient, but also to communities. And neighborhoods and villages in the past have been quarantined. Interestingly enough, as Africa has grown, remember the population of Africa has grown by 300% in the past 40 years, and many people are urban dwellers, so the isolation and quarantine matters are not quite as straightforward as they once were. Social distancing, that is, canceling major events where large numbers of people come together to try and keep people apart. Talking to people about the risks regarding burial, part of the burial ritual in many of these cultures involves washing the body, handling the body, and really coming in contact with infected secretions and body fluids before burial. Travel restriction has played less of a role here. But healthcare settings, as I said, are amplification points. And if you look at the number of healthcare workers who have been infected, 240 at last count, and 120 of them have died, you can see that this is a serious issue for healthcare workers as well. Other prevention measures are unique to this particular infection. And we've talked about the containment issue. There are some cultural issues, though, that enter the picture, and that's discouraging bushmeat consumption, that fruit bats as a source of food is in direct conflict and presents a serious risk to people, because bats are not only a food source, but they're part of the host and reservoir nexus. So people are trying to introduce livestock as a food source. There are always conspiracy theorists, and we need to overcome that. We can do that right here in the United States, I think. The government invented it, not. It also helps to destigmatize this. Remember that people are with mysterious diseases that are associated with death are often stigmatized. Certainly in my world, HIV has been a huge part of that. And then some of these other matters. So there are cultural and social issues that need to be overcome here if we're going to really get our arms around this disease. I'm going to tear through the treatment issue so that we have some time for questions at the end. Pat, just send me a message when my time is up. Treatments, passive therapy, that's convalescent therapy. It's been used several times in this epidemic, where people receive transfusions, blood transfusions, with the blood of someone who has recovered. Has been used many times in the past with other diseases, and also has been used historically with Ebola. The new kid, though, the new kid on the block is this monoclonal antibody. You may have heard of what's called ZMapp, made by Biopharma. It's a three antibody cocktail, not a drug, antibody, generated from tobacco plants. Tobacco plants are very efficient manufacturers of genetic material, and has been shown in animal studies to clear virus. It's also used in two Ebola patients who were transported to the United States. Both of those people survived. Now, the issue is, well, was it ZMapp that saved him, or was it good timing or a healthy host healthy immune system or being shipped to the United States for care, and I think all of that contributed to it. My point here is that if you really want to make firm conclusions about the roles of some of these newer therapies, you need a clinical trial to do it. But I still think there's room for this sort of thing. But remember, treating individual cases like this brings up ethical issues and also really brings up supply issues, that it takes a lot of time and effort and money to prepare this material, and it is in very, very short supply. What are monoclonal antibodies? Well, they're designer drugs that target a specific antigen. And as I said, the ZMapp drug was made in tobacco plants, but it can be done with recombinant technology or in animals or even human cells. The problem is that the purification and preparation steps, once the antibodies are quote-unquote grown, the purification process is really very time-consuming and expensive, because what you really want is that specific antibody, monoclonal antibody toward that specific antigen. So it's time-consuming. On the other hand, there are some late breakers here. People really are responding to the need. Three major U.S. government agencies are working to bring more monoclonal antibody, bring it to patients, bring it into human testing and clinical trials, and also activity to develop drug therapies and vaccines. So there is a significant amount of movement here to really address treatment of Ebola and address treatment beyond just supportive therapy. As I mentioned, those ethical issues are still there. If you have an agent that might work and is in short supply, who do you give it to? Well, I'm not going to try and answer that except to say, for the most part, those monoclonal antibodies that have been available have been given to healthcare workers or people who are taking care of patients. The World Health Organization has jumped on this, and they concluded at a panel in August that indeed it was ethical to offer unproven interventions, provided all of these conditions were met in terms of transparency, community involvement, and certainly data sharing, so that we can understand even one case at a time what's going on, and having some clarity in terms of how these agents might work and what their value is while we're waiting for the results of a clinical trial. We've done this with HIV. We did this right in the very beginning, so that it's a stepwise process, but at the end of all of that, there are opportunities to get data and have a clearer understanding of what's going on. I've already talked about untested treatments and the need for field trials. How do you distribute limited supplies of material? And there are also financial issues involved. Let's close here with what's the role of the community physician. The real role is very early recognition, protecting staff and patients. If you have a patient in whom you suspect Ebola or hemorrhagic fever, begin the isolation process. What it boils down to is begin the isolation process as soon as possible. Implement control measures and call your local health department. We've talked about this before in these webinars, but this is an opportunity and a necessity in terms of collaboration between the medical community, those of us who are on the ground taking care of patients, and our public health department, so that the local health department is the natural next step in terms of mobilizing whatever needs to be mobilized to address the issue and make sure that that person either is or is not infected, but to certainly add some clarity to the issue. One of the things that we saw in the more recent case at Mount Sinai Hospital in New York is just such a patient presented to the family physician, who did just what we just said, which was send the patient to the emergency department, but called the health department and then called the emergency department to put them on the alert so that by the time the patient arrived at Mount Sinai, they were ready for him. And that's what preparedness is about. So I'm going to slow down here for a minute and ask Pat if this is a good time to have some discussion. The rest of this talks about, here are my collaborators, thank you all. I had a lot of help with this. I did not do this alone. So I thank my collaborators for helping get this prepared in record time. And even though we had a little glitch here, we made it. Pat?
Okay, thank you, Dr. Valenti. We will entertain questions. So either if you want to ask a verbal question, if you are on the computer, you can hit the raise hand. Can you show folks how to do that? Raise the hand. And you'll see it's next to my name if you want to ask a question. Or you can actually send us a chat, and we will ask that question for you for Dr. Valenti. So are there any questions? Okay. At what point does the Ebola patient become non-contagious?
When at what time, when does the Ebola patient become non-contagious? When they start to feel better. We usually give them 10 to 14 days as an outside edge, but also as the fever subsides and patients become more stable, they become less infectious. But they don't just become non-infectious in one day. Remember how the viral load increases in 72 hours during the course of infection as fever subsides and the immune system takes over. It can be as long as a week or two, viral load begins to drop off.
Okay, any other questions? I don't see any. I will tell you that the evaluation is now open, so if you want to start filling that form out for us. Again, I'd like to add my apologies for our technical difficulties, but I think we've got them resolved. All right, and we have one other question. Yes. Why are none of the antiviral medications being used against Ebola?
Good question. There was some discussion of ribavirin might play a role, but the experience to date is that the current antivirals that we have available are not effective. So it becomes a matter of either developing new antiviral agents, or the other thing is there may be something sitting on the shelf that can also be tested. But that's an active area of investigation. Good question. One other, do you have a question, Pat?
Yeah, I'm looking, Bill.
I have a question about what about this becoming an agent of bioterror, that sort of thing? Can it be used as a weapon of destruction, mass destruction? There's actually some experience with this. A Japanese group tried to do this and failed. This is a very tricky virus and doesn't lend itself to that sort of thing. I know some of you may have seen a report of a needle stick that occurred at an airport in Africa that was thought to be Ebola. It turned out not to be. So the short answer is this has been brought up, but it does not seem to be a very at least to date, the experience has been that it doesn't lend itself to that kind of weaponizing.
Okay, we have another question. What do we do with patients in the same waiting room as a possible Ebola case?
Well, those are patients who are followed and tracked by the health department, and the short story is that what you'd be looking for in those people is over a 21-day period for the development of fever. At the beginning and the end, you'd also consider drawing blood at the beginning, drawing blood at the end. Remember some of those laboratory people who were in the vicinity of Ebola, or the people on the airplane? The same sort of thing is you'd isolate people like that for 21 days and keep an eye on them and watch them with either blood surveillance to see if they developed antibody or see if they developed a fever. Now, some of this will change. I realize this is may not be entirely comfortable for people, but as drugs and other preventive strategies, biomedical kinds of strategies are developed, that some of that may change. So it's very much a work in progress. But the surveillance piece is the way it would be done today. Okay. Are we still here? Oh. Are we on? Uh-oh. Is this connected?
Dr. Valenti, I have another question.
Okay.
How did the obstetrician who contracted Ebola but apparently was not attending patients who had Ebola get the disease?
I'm not familiar with that one. Let me suggest that the person answering the question just provide me with a little more detail, either to you, Pat, by email or some way, and I will. I'll try and research it and get the answer. But I'm not familiar with the obstetrician case or where that case may have occurred.
Right. Are people who survive Ebola now immune to all strains?
Good question. I can tell you what those people, what we know, and that is that those people are a good source of antibody that can be used to transfuse into people who are sick. So that's that passive antibody transmission. In terms of overall immunity, we're not sure because there are other strains of Ebola that are different genetically. For example, Zaire versus Sudan, there is some variation there. So the immunity may not be 100%.
Okay, any other questions? Okay, I will say that the poll remains open for people to fill out the evaluation, and we're going to give you all a few minutes to do so. In the meantime, I'd like to take this opportunity to thank Dr. Valenti for his presentation this morning. And if there are any questions, obviously you can either email them to me or Shakira Kramer, and I'm at pclancy@msny.org, or Shakira Kramer is skramer@msny.org. Our next medical matters will probably be in February of 2015. There are advocacy matter webinars that will continue throughout the fall, and there are e-prescribing webinars that are upcoming soon. The next one is September 24th. Yeah. So. Yes, and this program on Ebola will be archived and it will be available on the WebEx system and also on our MSSNY online program. So, Bill, I'd like to thank you. If you want to just hold on for a few minutes, or if you want, you can hang, whatever you want to do. Do want to have a conversation with you in regards to other matters, all right?
Gotcha. So, and can I make my financial disclosure now? Am I still on? I have no disclosures. Did it?
Oh my God. It looks like we only have like 3 people left to take the poll. 1's in progress, 4 is just kind of hanging out. That's almost done. People are...
Oh, I'm done. I'm going to need to click.
Okay, we are officially going to let Dr. Valenti go. We will have the poll open for the next 4 minutes if you want to complete this, and I want to again thank you everyone for their participation today. Your certificate will be emailed to you within the month. Thank you.